The title of this lecture is Arrhythmias. My name is Melanie Maytin. I'm an instructor of medicine at Harvard Medical School and a member of the Brigham and Women's Cardiac Arrhythmia Service. I have no conflicts of interest relevant to this presentation. An overview of what I'm going to be speaking about starts off with arrhythmias or tachycardias, specifically pathophysiology, with a bit of focus on individual rhythms and medications, followed by a general approach to tachyarrhythmias, and then more specifically supraventricular tachycardias, ventricular tachyarrhythmias, some syndromes that are worth hearing about, and then following up with bradycardia. So there are three primary mechanisms by which tachyarrhythmias can occur. Automaticity, abnormal automaticity results from an automatic impulse generation from an unusual site that overtakes the sinus node. Triggered activity occurs as a result of secondary depolarization, either during or after repolarization. And reentry, which is the most common mechanism of tachycardias, accounting for approximately 90% of arrhythmias. And there are specific criteria that must be present for reentry to occur. Specifically, there have to be two separate pathways for conduction, an area of slow conduction, and unidirectional block. Most classically, this is represented by dual AV node physiology, resulting in AV-NRT, or atrioventricular nodal reentry tachycardia. Also seen with bypass tracts and AV-RT, or atrioventricular reentry tachycardia. But where we do see a lot of reentry arrhythmias is when there's scar in the myocardium, because this results in multiple circuits with the aforementioned criteria and can result in arrhythmias. So let's shift gears and talk about antiarrhythmics a bit. The Vaughan-Williams classification of antiarrhythmic medications has been around and in use for quite some time. It classifies medications into four classes, which I'm sure you all are familiar with. Class 1 being sodium channel blockers, further subdivided into 1A, 1B, and 1C. 1A agents such as quinidine, procainamide, disopyramide actually increase the height of the action potential. 1B agents such as lidocaine decrease the height of the action potential. 1C agents like flecainide actually have no effect on the action potential. Class 2 agents encompass beta blockers such as atenolol and sotalol. Class 3 antiarrhythmics are potassium channel blockers, and they prolong both the action potential and the refractory period, classically consisting of amiodarone and sotalol, although amiodarone really can have properties of multiple classes. And class 4 agents, which are calcium channel blockers or antagonists that impair impulse propagation in both nodal tissue and areas of damaged tissue. One example would be verapamil. So different areas within the heart are affected differently by medications. So the AV node, for example, is very sensitive to acetylcholine. So vagotonic or vagal maneuvers can be effective in affecting arrhythmias that involve the AV node, as well as both calcium channel blockers and beta blockers. Accessory pathways or atrial or ventricular tissue can be affected by class 1 agents such as procainamide, flecainide, and propafenone, or potassium blockers such as the class 3 drugs amiodarone and sotalol. And there's, sometimes there can be sympathetic stimulation present or involved in the arrhythmia, and so beta blockers may have effect in those instances as well. Specifically looking at types of tachyarrhythmias, they range from sinus tachycardia to sinus node reentry tachycardia to the ones that we really commonly encounter in clinical practice, such as AV-NRT or AV-RT, AV-nodal reentrant tachycardia or atrioventricular reentrant tachycardia, atrial tachycardia, atrial flutter, atrial fibrillation, multifocal atrial tachycardia, and ventricular arrhythmias such as monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, ventricular fibrillation, and the less commonly seen ventricular flutter. So really, when faced with an arrhythmia, the most important question to ask first is there time to think about it? And if the patient is hemodynamically unstable, electricity is always the answer. Hemodynamic stability is dependent upon a number of variables, including the rate of the arrhythmia, the underlying ventricular function, and the sympathetic nervous system response to the tachycardia. So it's not the time to think about what the source of the rhythm is when a patient is hemodynamically unstable. The rhythm needs to be terminated urgently. Manifestations of hemodynamic instability include hypotension, altered mental status, congestive heart failure, angina. These are all symptoms that indicate organ dysfunction and require rhythm termination. So rhythm termination can be done by cardioversion if there's organized ventricular activity, or defibrillation or asynchronous cardioversion for rhythms like ventricular fibrillation or anything where someone is actually pulseless with the rhythm. When you have time to think about the rhythm, the first question that we tend to ask to classify the type of rhythm is the rhythm narrow? Specifically, is the QRS duration less than 120 milliseconds? If it is, it's most likely that it's going to be supraventricular tachycardia. That being said, VT can be narrow. In fact, if the QRS duration in the arrhythmia is more narrow than in sinus, then it likely is VT. If it's wide, it could still be SVT, but really should be assumed to be ventricular tachycardia until you can prove to yourself that it's supraventricular. And in fact, among those with a history of myocardial infarction, wide complex tachycardia can be assumed to be VT with greater than 95% certainty. So focusing specifically on narrow QRS complex tachycardias. So in the hemodynamically stable patient, the first question in trying to identify what the rhythm is it regular or not? If it's not, then it's likely going to be either atrial fibrillation, an atrial tachycardia or atrial flutter with variable block, or multifocal atrial tachycardia. If the rhythm is regular, we then want to see, is there any evidence of atrial activation? And we determine that by looking for P waves. If you do not see P waves, this is the so-called no RP tachycardia, it is most likely going to be AV NRT or AV nodal reentry tachycardia. If you do see P waves, then you want to know, are there more A's than V's? If the answer is yes, then you're dealing again with atrial flutter with some degree of block or atrial tachycardia with some degree of block. If not, we start focusing on the RP interval, or the timing between the R and the visible P wave, and compare it to the PR interval. Short RP tachycardias are like no RP tachycardias and are most likely AV nodal reentry tachycardia. Long RP tachycardias could still be AV nodal reentry tachycardia, but also could be AV reentry tachycardia or atrial tachycardia. In this EKG, we have a narrow complex tachycardia at a rate of about 160, 170 beats per minute. And we have a rhythm strip, or part of a rhythm strip, from sinus rhythm after termination of the arrhythmia. And specifically focusing on leads 3 in AVF, we can see that this terminal S, or S wave that was present before in leads 3 in AVF is now gone. So this is a pseudo S wave in tachycardia, and this likely represents atrial activation. And this short RP tachycardia is likely AVNRT with evident retrograde P waves. So how do we manage the patient with hemodynamically stable, regular, narrow QRS tachycardia? Well, vagal maneuvers certainly can be tried, but IV adenosine is a reasonable way to both treat and diagnose the arrhythmia. Recommended dosages are 3 to 18 milligrams of IV push followed by a large saline push, but we usually start with 6 milligrams of adenosine. It will result, if the dose is sufficient, it will result in transient AV nodal block, approximately 5-6 seconds in duration. It can also affect the sinus node and the atrium, and can even initiate atrial fibrillation due to its effects on atrial tissue. Patients will experience brief discomfort, and it's always reasonable to warn them of that. They can have chest pain, dyspnea, and the administration of adenosine can be helpful to both diagnose the arrhythmia and terminate, as mentioned before. It should not be administered in patients with cardiac transplantation, acute asthma, or WPW. So following administration of the adenosine, if you have no change in the arrhythmia, either the dose was inadequate or this is a ventricular arrhythmia. If you see a gradual slowing then reacceleration, this is more likely to be sinus tachycardia, junctional tachycardia, or an atrial tachycardia. The presence of persisting tachycardia, however, with AV block helps with the diagnosis of atrial flutter or atrial tachycardia. If you see sudden termination, it's most likely going to be AV nodal reentry tachycardia or atrioventricular reentry tachycardia. There is a small percentage of atrial tachycardias, about 15 to 20%, that are terminated with adenosine, and also sinus node reentry tachycardia is in the differential. So here we have a narrow complex tachycardia that is regular, and it's at about 140 beats per minute, and we are looking to see if we see any evidence of atrial activation or any P waves, and we get the hint that, maybe there's something else buried within the T wave, around the terminal portion of the T wave. Adenosine is administered, and we unblock flutter waves. So while it did not terminate the arrhythmia, we have ongoing atrial arrhythmia with AV block, and we're able to diagnose atrial flutter. Considerations specific to the intensive care unit. Sinus tachycardia. It's a result of increased automaticity of the sinus node in the setting of critical illness, adrenergic medications, hypovolemia, and inflammation. Classically, if you look at the cardiac compass to see the trend, you'll see that there's a gradual increase in rate, and the treatment really should be geared towards the underlying condition. There are certain situations, however, that may warrant rate control rather than treating the underlying condition, such as those patients with critical coronary disease or diastolic heart failure. Atrial tachycardia has similar triggers as sinus tachycardia. You can use class 1 antiarrhythmic medications to either terminate or prevent the arrhythmias. However, frequently treatment of the underlying problem is sufficient to manage the arrhythmia. AVNRT is the most common regular SVT that's seen in clinical practice, counts for about 60% of cases, is more common in females, usually in ages 20 to 40. They do typically have a history of AVNRT or palpitations dating back to their teens. The typical pattern is slow, fast, antegrade down the slow pathway, retrograde up the fast pathway, resulting in a short RP tachycardia. It can be terminated with vagal maneuvers, adenosine, and either calcium or channel or beta blockers. And it rarely requires antiarrhythmic medications or urgent ablation. Atrioventricular reentry tachycardia is a muscular connection between the atrium and the ventricle that bypasses the AV node. Actually more common in males, usually have a history of tachycardia or palpitations dating back to the teens as well. It can result in ORT or orthodromic reentry tachycardia, where the circuit is antegrade down the AV node and retrograde up the accessory pathway, resulting in a narrow complex tachycardia. Or ART, which is antidromic reentry tachycardia, where the circuit is antegrade down the accessory pathway and retrograde up the AV node, yielding a wide complex tachycardia. Can be terminated with AV nodal blockers, adenosine, beta blocker, etc. However, pre-excited tachycardias, meaning supraventricular tachycardias down the bypass track, is bypassing the AV node due to the accessory pathway. So in these cases, AV node blockade is really contraindicated, and the best management options include procainamide or urgent cardioversion. Atrial fibrillation is by far and away the most common type of arrhythmia seen in the ICU. It may be problematic due to hemodynamic instability, due to rapid ventricular rates and shortened diastolic filling time. And another important consideration is the potential for left atrial thrombus formation that needs to be considered in managing patients with atrial fibrillation. Number of risk factors that can result in atrial fibrillation and commonly seen in the post-surgical state and with an even higher incidence in post-cardiac surgery or post-thoracic surgery. And the management, specifically rate versus rhythm control, as well as thought to anticoagulation, should be individualized. Antiarrhythmic options for atrial fibrillation include ibutyline, which is really only used for acute conversion. It has an efficacy of about 30% for atrial fibrillation, 60% for atrial flutter. There is a risk of torsade de pointes that is as high as 8%, and patients need to be monitored carefully for a period of 6 hours following administration of ibutyline. Typically best to co-administer magnesium regardless of serum magnesium levels with the administration of ibutyline. Procainamide is another option, however less effective than ibutyline for acute conversion, but could be used for maintenance. There is a risk of hypotension and proarrhythmia. And amiodarone. The intravenous formulation really has almost no acute antiarrhythmic effect, but is very good at controlling rates. And just a note that is not really approved by the FDA for acute atrial fibrillation. It does have good efficacy during chronic therapy. Should never be administered via peripheral IV because of the risk of severe thrombophlebitis with extravasation of the medication, and should be administered via a central catheter. So catheter ablation for atrial fibrillation. Success rates range from 60 to 85% after a 3-month blanking period, depending upon whether someone has paroxysmal or persistent atrial fibrillation. During that blanking period, you actually may see more atrial arrhythmias than prior to ablation, and has a complication rate that approaches 2.5% in all complications. It really has no real role in the acute setting for the management of atrial fibrillation. In contrast, ablation for typical flutter has an acute success rate that's almost 100%, with long-term success of greater than 90% for recurrent atrial flutter. And significant procedural complications are fairly rare, complication rates approximately 1% or less. The caveat being that there is a significant percentage of these patients that go on to develop atrial fibrillation, sorry. So moving on to wide complex tachycardias. There are a potential of etiologies of wide complex tachycardias. It could be ventricular tachycardia, could be an SVT with aberrancy, or could be a paced rhythm. These are typically the regular wide complex tachycardias that are encountered. If there is an irregular wide complex tachycardia, but with a uniform QRS, most likely going to be supraventricular with either atrial fibrillation or flutter. However, if you see an irregular wide complex tachycardia with polymorphic QRS complexes, really the thought has to send to polymorphic VT or AF with aberrancy. So accessory pathways with wide complex tachycardia result in irregular wide QRSs, often with variable morphology, as depicted in this short strip here. Management really consists of either procainamide or cardioversion, potentially ibutyline, but really nothing that affects the AV node. Antidromic AVRT or atrioventricular reentry tachycardia will result in a regular, wide, monomorphic tachycardia. Again, management includes procainamide, cardioversion. Hemodynamically stable patients, you could consider giving IV adenosine, although there is a small risk of provoking AF, and definitely not the test question answer. Markers of VT. When we look at a wide complex tachycardia and try to determine if it's supraventricular or ventricular in origin, there are a number of factors that we take into consideration. One is concordance. And by concordance, we mean that in the precordial leads that either there are no R waves, specifically negative concordance, or that there is no Q or S wave in the precordial lead, which would be positive concordance. We look at the intrinsicoid deflection and see if it's prolonged, specifically if the distance from the onset of the R wave to the nadir of the S wave is greater than 100 milliseconds, resulting in sort of a slurred or notched or very wide QRS complex. The presence of AV dissociation, where there are more V's than A's, is very helpful in the diagnosis of ventricular tachycardia. And the presence of fusion and capture beats can also help suggest AV dissociation. And finally, we can look at the morphology of the QRS complexes to help us determine if we think the rhythm is either ventricular or supraventricular in origin. On this surface electrocardiogram, we see a wide complex tachycardia. QRS is fairly wide. There is some notching in these QRS complexes, fairly monomorphic. And what we notice is that there actually is evidence of atrial activation in a 2-to-1 pattern, more visible in some of the channels versus others. If you look at an intracardiac electrogram from an implantable cardioverter defibrillator, and I'm just going to orient you before describing what we see, because you may not be as familiar with this. This is actually the near-field atrial channel, so it's a signal recorded by the atrial lead right where the atrial lead touches the atrial tissue. This is the near-field ventricular channel, where the ventricular lead is in contact with the myocardium. And this is the far-field ventricular lead, which is sort of a summation that takes it from the electrode that's touching the myocardium to the can or defibrillator generator itself. And what we see here is we see that all of a sudden there are a lot of V's that occur, both seen in the near field and far field ventricular channels, while the atrial rate really remains relatively unchanged. So the presence of more V's than A's is AV dissociation and diagnostic of ventricular tachycardia. The device actually recognizes this, and these F's represent that this detects it as a tachyarrhythmia falling within the VF zone. So morphology criteria that favor ventricular tachycardia. When we look at a wide complex tachycardia, we tend to describe it as either right bundle or left bundle in pattern, primarily based upon its appearance in V1 and V6. So for a right bundle wide complex tachycardia, when we look at V1, if there is a monophasic R or a dominant R with either a small q or a small s, this is more suggestive of ventricular tachycardia. Similarly, in V6, an S wave that is larger than the R wave or a predominant QS wave in V6 are more consistent with ventricular tachycardia. For those with a left bundle, arrhythmias with a left bundle branch pattern, looking at V1 or V2, we see a very wide QRS with an intrinsicoid deflection that is greater than 60 milliseconds or a broad R wave greater than 30 milliseconds. And in V6, we see small Q waves with either a dominant R or a dominant S, and those morphologic patterns favor ventricular tachycardia. So how do we manage the hemodynamically stable patient with a regular wide QRS tachycardia? Well, if we are positive that it is SVT, we can proceed to manage the patient using the narrow QRS algorithm as previously discussed. But if we're not positive that it's SVT, we have to assume that it's possibly VT. Antiarrhythmic medication options include procainamide, amiodarone, sotalol, less commonly lidocaine. However, with amiodarone being far and away the medication that's used in these situations, and cardioversion is always an option. It's worthwhile keeping in mind that drug toxicity and electrolytes can affect and even cause ventricular arrhythmias. In describing ventricular tachycardias, we often talk about monomorphic versus polymorphic and even sinusoidal. So monomorphic wide complex tachycardia, as mentioned, we think about, is this ventricular tachycardia or is this an SVT? When it's polymorphic VT, really, first and foremost, we should be thinking about ischemia in those patients whose QT is not significantly prolonged on baseline ECG. Or torsade de Pointes, whether congenital or acquired, genetic syndromes that can result in polymorphic VT, and idiopathic VTVF. Sinusoidal rhythms, wide complex rhythms, are usually a result of severe profound hyperkalemia or drug toxicity. So polymorphic VT, as mentioned, we really divide them up into those with normal baseline QT and those with prolonged QTs. So those with normal baseline QTs, the management options include antiarrhythmics such as amiodarone primarily, without fear of lengthening the QT further, beta blockers, magnesium, and really first and foremost ischemia should be in the differential as well as correcting any other permutations that exist. If someone has a prolonged baseline QT, really the management consists of repleting magnesium and increasing the lower rate so as to avoid torsades. Increasing the lower rate, the patient's lower rate can be achieved either pharmacologically with agents such as isoproterenol or electrically with a temporary pacing wire. Lidocaine can also be used in this situation. Some rarer disorders to keep in mind. So idiopathic VT is a relatively benign arrhythmia that occurs in the structurally normal heart. It can originate in either the right ventricular or left ventricular outflow tract. It's a result of enhanced automaticity and it can be incessant, but as stated, generally has a good prognosis, very readily treated with catheter ablation. Left ventricular septal VT, which encompasses verapamil-sensitive fascicular and Bellhausen's VT, is a reentrant tachycardia that has a right bundle branch pattern but with a narrow QRS, thought to be very responsive to verapamil and frequently confused with SVT. Arrhythmogenic RV dysplasia or cardiomyopathy is a result of fibrofatty replacement of the myocardium. It's classically occurs in the right ventricle, although the left ventricle can certainly also be affected. Unfortunately, ventricular arrhythmias are frequently observed in this condition, and the baseline ECG can have suggestive features but could also be normal. Up to 85% of patients with ARVC are described as having T-wave inversions in the right precordial leads. A small percentage have right bundle branch block or the presence of an epsilon wave. Brugada syndrome is an inherited condition that can have different ECG manifestations. The concern is the risk of sudden cardiac death from polymorphic VT or VF, and that can occur during sleep or during periods of stress, and specifically with fever. Patients can also have manifestations of atrial arrhythmias and atrioventricular block. The risk of cardiac arrest is a bit controversial. It is thought to be as high as 10% per year if there is a history of arrhythmia symptoms. ICDs can be protective in certain populations of Brugada, while medications have not been proven thus far to be protective. And these patterns can be mimicked by many other processes. One comment would be that these changes can be evanescent, and it can be that you only see these changes in the setting of fever or severe stress. And so you can see that maybe someone who has a suggestive type 1 pattern but doesn't necessarily meet criteria at other times of severe stress could actually have that manifest pattern. Congenital long QT is an inherited channelopathy that affects both sodium and potassium currents. There are a number of different channelopathies. However, the three most common have been described as long QT 1, 2, and 3. They give different patterns of QT prolongation, with long QT1 giving a broad, wide T wave that is prolonging the QT segment. Long QT2 classically has a notched T wave, and long QT3 has this very long QT segment with a discrete T wave. Traditionally, long QT1 has been associated with sudden cardiac death while being physically active, classically swimming. It is the result of a potassium channel mutation, and beta blockers have proven to be somewhat effective in limiting sudden cardiac death risks. Long QT2 is also a potassium channel mutation, classically associated with emotional episodes or sound stimuli, classically described as the alarm clock going off. Long QT3 is actually a sodium channel mutation with the classic description of sudden cardiac death while asleep. Long QT can also be acquired, and there are a number of drugs or electrolyte abnormalities that can result in a prolonged QT, as shown on this surface ECG, where the QT interval is approaching 600 milliseconds, and when the offending agent is removed, you see that there's dramatic shortening of the QT interval. Bradyarrhythmias. So bradyarrhythmias can affect the sinus node with resultant sinus bradycardia, sinus node exit block, sinus arrest, or what we call sinus node dysfunction, can affect the AV node with different types of AV block, type 1, type 2, and high grade or complete heart block, and can affect the His-Purkinje system. If conduction block is below the level of the AV node, it is important to note that atropine will not help improve conduction. So it is important to realize that problems with the conduction system can be dynamic. And really, it's the reliability of the escape rhythm that drives how we determine how to manage patients. In general, escapes in or above the AV node are thought to be reliable, while those below it are not. But symptoms really matter more than numbers or other concrete specific factors. Permanent pacing really should be avoided in those cases of reversible or transient bradycardia, such as heightened vagal tone, drug toxicity, and Lyme disease. Another manifestation of a type of bradyarrhythmia is tachybrady syndrome, and this is manifest by the presence of atrial tachyarrhythmias, be it atrial fibrillation, atrial flutter, atrial tachycardia, some other SVT, and sinus node dysfunction. So you have rapid rates while in the tachyarrhythmia and either slow rates in normal sinus rhythm or significant symptomatic sinus offset pauses. So the options are to either get rid of the tachyarrhythmia or to implant a pacemaker to allow medical management. And here we see evidence of AV nodal disease. So we have a person who has high-grade AV block is manifest by a number of non-conductive P waves before this escape beat occurs, followed by a PVC. So with AV block, we tend to talk about Mobitz type 1 and type 2. So Mobitz type 1, or Wenke block, is where we have progressive prolongation of the PR interval before a non-conducted P wave. So you can see here that the PR interval progressively prolongs before it is dropped and not conducted. It is typical of disease within the AV node and typically portends a benign prognosis. Trifascicular block is the classic right bundle, left anterior fascicular block, prolonged PR. In and of itself, it is not a indication for pacemaker therapy. Mobitz type 1, again, where we see that there's progressive prolongation of the PR interval before a non-conductive P wave. If we measure this PR interval and compare it to the last previously conducted PR interval, we'll see that this is actually shorter, helping us with the diagnosis of Mobitz type 1. Now, I stated that this is usually associated with benign prognosis. However, it does not guarantee it. So here in the same patient, later developed complete heart block with AV dissociation, evidenced by a higher number of A's than V's, and now a wide complex ventricular escape rhythm in the rate of 30 to 40 beats per minute. Take-home points. If the patient is hemodynamically unstable, electricity is the best answer. If you're presented with a wide complex tachycardia, it is best to assume VT until proven otherwise. If you have a patient with a supraventricular tachycardia, vagal maneuvers and adenosine can be used to diagnose and treat unless you have WPW. With an accessory pathway, we should probably best to avoid nodal agents or other interventions. Think about procainamide or electricity. Heritable arrhythmic disorders, you will not encounter them unless you think of them. And with bradyarrhythmias, really it's the patient's symptoms and the reliability of the escape mechanism that drive device and pharmacologic management. And we're going to go on to some questions. So you're presented with the following ECG. You can see that the patient is in the emergency room and has 4 out of 10 chest pain. There is an intervention that is performed, and we have the resultant ECG. And the question is, all of the following should be avoided in this patient except. And the answer is really procainamide. What we saw was a wide complex tachycardia that was irregular with some differences in QRS morphology. And this actually is pre-excited AF or AF with WPW. When the patient, when normal sinus rhythm was restored, we now see the patient has a very short PR interval with a slurred upstroke to their QRS, or so-called delta wave, indicative of antegrade conduction down an accessory pathway. And in patients with WPW and AF, really medications that block the AV node should be avoided. Procainamide or electricity would be the management options of choice. Procainamide will help slow conduction in the bypass tract. You're presented with the following ECG. If this patient's arrhythmia is drug associated, possible treatments include all of the following except. And the answer really is start sotalol. Given its known association with QT prolongation, sotalol and other QT prolonging medications really should be avoided in this patient. If we go back, what we see is a salvo of really polymorphic VT and really even torsades with a twisting of points going from a negative QRS to a positive QRS to a negative QRS in this rhythm strip, followed by sinus rhythm with a massively prolonged QT interval. The QT interval is just barely finishing as the P wave is beginning. And increase in the lower rate, either electrically or chemically, repleting electrolytes, as well as the use of beta blockers, ideally in the presence of temporary pacing support, because bradycardia would not be a good option for this patient. Okay, so you're presented with the following ECG. And the question is, which of the following is a true statement? And this could be either Mobitz 1 or Mobitz 2. So if we go through the answer choices, even if we were sure that it's definitely Mobitz 1, we cannot say that it never requires a pacemaker. It's really rarely requires a pacemaker. If someone's highly symptomatic, pacemaker implantation would be indicated. But in reality, when we go back, what we see is that there is 2-to-1 AV block. So we see 2 P waves, one conducted and one non-conducted. So in 2-to-1 AV block, we can't definitively state whether this is Mobitz 1 or Mobitz 2. So obviously, while the second portion of this statement is correct, the first portion is not. So C might have been something that people selected. So if Wenke-Beck pattern is observed in any associated tracings, then this will not be high-grade AV block. It is true that while the observation of Mobitz 1 in association with tracings is, with the tracing shown before, is generally reassuring that the 2-to-1 block is likely Mobitz 1, it's still possible that high-grade AV block exists. It's definitely Mobitz 2, an indication for a pacemaker. So Mobitz 2 would be an indication for a pacemaker. As aforementioned, can't say that 2-to-1 AV block is either Mobitz 1 or Mobitz 2 definitively. And yes, there was sort of a wide QRS in the CCG, which might make us concerned that this is more likely Mobitz 2 because the patient could have other coexisting conduction disease. This patient did go on to have high-grade AV block as evidenced by several non-conducted P waves, and so therefore ended up to have more than just Mobitz 1.